Well, good morning.
Good morning.
How are you today?
I'm not sure. I'm a little nervous about being here.
Okay. Well, it's good to see you here. I hope I can help. What is it that you understand is going on?
Well, I'm not sure I understand much. I went to see my primary care doctor, and he told me I was having some trouble with my kidneys.
Okay.
And he told me that I had blood and protein in my urine, and he gave me a long name of a disease, but he didn't really explain what was going on. All he said was, I need to go see you.
Okay.
So he said, go see Dr. Lafayette, and he'll take care of it.
Well, I certainly hope that's going to prove to be helpful. I have looked at your records, and indeed you do have some blood and protein in the urine. Do you know if that's been around a long time or not?
I'm really not very sure. I think it hasn't been more than about 6 months.
Okay. And then I know your doctor had made sure you got that biopsy done, and that long word that the doctor was saying was just IgA nephropathy. Does that sound familiar?
That sounds exactly what he said.
Okay. And I can tell you a little bit about that disease, and then we can talk about what we try to do to make sure that it's as well controlled as possible and causes you as little trouble in your life as possible. Is that okay?
That would be wonderful, because I think that's my biggest fear, is that it can't be controlled and it's just going to take over my life.
Well, again, what this disease is, again, called IgA nephropathy, this stands for immunoglobulin A nephropathy. And what that really just means is that antibodies, part of your body's immune system, have been formed and are depositing in your kidney. And the reason that seems to happen is that sometime in your life, you probably had some exposure to some stress, to some substance, or more likely an infection, and that turned on your immune system. And certain people in the world are just predisposed to have a reaction where you react to that stress, but the immune system never calms down. And so you persistently make these antibodies, and then a further small subset of patients actually can react to those antibodies, making antibodies to the antibodies, and then you have this whole inflammatory substance floating around in your blood. And in a subset of those patients, they're lucky enough, like you, where it deposits in the kidney, and then the immune system can focus on the kidney, causing inflammation and harm potentially to the kidney. Is that making any sense?
It is. Is there anything that I did to cause this? Would that be?
That's a great question. Probably not something that you did at all. Again, it's some exposure that you probably had. It's probably just the genes your parents gave you, although this disease doesn't frequently run in families. Only about 1 in 20 patients have a family history. But still, it's something your body is still doing that's causing the inflammation in the kidneys to cause the blood and protein that we can see, because it inflames the small blood vessels within the kidneys that make blood turn into what eventually will become your urine. And the blood and the protein should stay in the blood and not end up in the urine. So it's just a sign of the inflammation in your kidneys. And our goal will be to try to limit that inflammation, to limit the protein leak, because ongoing inflammation, ongoing protein leak could then lead to further harm in your kidneys. And in some patients, it can be very scary. The kidney disease can get worse, and patients can go on to lose their kidneys.
So what do we do to start the treatment? Is there something I need to take? Do I need a lifestyle change? Do I need to change what I eat?
That's a great question, and really, really important. First off, you have to understand that in most patients, this is a very slow-moving disease. It's also without any symptoms, so you often don't feel anything. I understand you're not feeling anything, are you?
No, there's no pain, no.
Good. And what we want to do is we want to start with things that you can change, that you can take control of in your own life, and then we talk about specific medications, okay? Where we like to start is just for you aiming to be as healthy as you can be, with good, healthy diet, regular exercise, keeping as fit as possible, because all those things are good for your body, good for your kidneys. Specifically for the kidneys, any kidney stress is bad, and a lower salt diet slight protein restriction tends to be a good thing for your kidneys. Also, making sure we don't do something separate to harm the kidneys is really important too. So any new medications, and particularly non-steroidal anti-inflammatory drugs that you probably know as naproxen and Aleve and Motrin and ibuprofen, generally ought to be avoided. Is that sounding good so far?
So I run every day. Can I continue to do that?
Yeah, I would love you to be active and fit. Those are good things for the kidneys. People sometimes worry about getting too dehydrated, but you just have to drink to your thirst. Always have a little water available if you're really exercising hard, and that's absolutely fine.
So I don't have to change my regimen of running a few miles a day?
No, that's absolutely wonderful for you. You should continue doing that. But what we have to do beyond diet and exercise is focus on blood pressure. Blood pressure often gets elevated in these illnesses, especially as the kidney weakens, and it's important to keep the blood pressure well controlled. We generally want to keep the blood pressure pretty much normal, which is less than 130 over 80 millimeters of mercury. So you're going to want to start following that at home, probably every week, and making sure that you're in that range. Is that something you could do?
Absolutely. When I exercise, my little machine takes my blood pressure, and
Good.
I can record that.
And your blood pressure's been running pretty normally, I understand.
It's been running even normal, kind of on the low side.
Okay. Well, that's terrific. The other thing that we like to do is, even when your blood pressure is normal, we try to rest the kidney and take away further stress with a group of drugs which block a hormone system. They're called RAS inhibitors. I know that's sort of a strange name, but it's a group of medications which lower the blood pressure in the body, but also do things within the kidney that help to reduce protein losses, help to reduce stress, and with the degree of protein loss that you have, that may be very beneficial for you. And studies have reliably and repeatedly shown it'll lower your risks in the future to have further injury to your kidney or to get closer to losing your kidneys over your lifetime.
Is there any side effects to these drugs that I have to be careful of? Is there any interaction? I've had Graves' disease since I was 17.
Mm-hmm.
So I've been on the same medication for the last, I don't even want to tell you, 40 plus years. Mm-hmm. Is there any problem with the interaction of those drugs?
So these medications are generally very, very well tolerated. They can have side effects. Some of them can cause cough. Any new medicine can cause some stomach upset, some rash, some headaches, but usually these medicines are very, very well tolerated. Because they're blood pressure pills, we have to make sure your blood pressure doesn't go down too low, that you feel dizzy or lightheaded or just not yourself. But generally, they're very, very well tolerated. And in fact, we do have to check blood tests within a couple of weeks to make sure that your kidneys tolerate them well and that the potassium in your blood doesn't go up, because that can be a rare problem with these medications as well.
So I get them tested, I'll get blood tested. Is that something that I continue to have to do over the course of the medication?
Generally, if you tolerate the medication at first, you'll continue to tolerate the medicine. But because of your kidney disease, we are going to be monitoring you relatively regularly. You'll have regular urine tests and blood tests. With your present disease, it'll be every few months. You'll need to see your doctor. Hopefully, you'll come back and see me every few months. And we'll monitor it, and you'll be able to contact us about how well your blood pressure is doing and how well you're tolerating this first medication. But there's still more to talk about.
Okay.
Okay. So these lifestyle changes, blood pressure control, and the use of these RAS inhibitors are a very important part of the therapy, but they don't go directly at the inflammation, at the immunoglobulins themselves. This disease has been known about for about 50 years, where these antibodies deposit in the kidney cause activation of a lot of inflammatory molecules called cytokines and complement, and we're trying hard to find ways to treat this. As you may have heard of, the most common anti-inflammatory drug that we use is steroids, drugs like prednisone. These medications have a long list of side effects like weight gain and personality changes, risks to blood pressure, cholesterol, mood, risks to the bones, and risk for infection. So we take them very, very seriously. Unfortunately, there's been very mixed results about these drugs over the last 5 decades, where studies mostly have shown that they're beneficial. If we don't see a really good control of your blood tests, and particularly your urine protein losses, we still might consider using steroids for your care. But we will have to discuss that very carefully because there are a lot of pros and cons.
Because I do have a history of high cholesterol in my family going back. And I myself have had borderline cholesterol problems. So is that something I would have to worry about, taking prednisone or another?
It's certainly something that we would follow and discuss. And if your cholesterol became high on the new medication, we would have other medications to offer. I know it starts getting sort of difficult because one medicine begets another medication, but that's why we would talk about the risks and potential benefits of these types of drugs. There are other therapies that are discussed because the prednisone can have lots of side effects. People have tried using companion drugs together with the prednisone to try to limit the injuries that occur and to limit the side effects. And that's been done with mixed results as well. So other drugs that have names like Imuran or azathioprine, Cellcept or mycophenolate, or cyclophosphamide have all been tried in this type of disease. And it's a long discussion about each one of those pros and cons, because these drugs have side effects as well. However, in the end, we often individualize them based on your situation and your response initially to diet, exercise, and to the blood pressure controlling medications.
And this is something I can do with you. This therapy would be done under your supervision, so to speak, and so that I could just come back and see you and I wouldn't have to rely on my primary care physician, because it made me a little nervous. I didn't think he really knew a lot about this disease.
Yeah, I think, again, that's a good point. The reason your doctor sent you to a kidney specialist is because we have more experience, both with the illness, hopefully with teaching you about it a little bit like I'm trying to do today, and then monitoring the disease and trying to know when these medications are properly used and properly stopped.
Would I need another biopsy at some point?
Presently, it's not our standard to do repeat biopsies in this disease, but there does come times in your life where the disease can change. Sometimes we get really good control of the illness, and we're very happy for several years, and then that control goes away. And sometimes understanding whether it's repeat inflammation, repeat severity of this IgA nephropathy, or just chronic wear and tear will lead us to ask for a new biopsy.
But I can continue to live the life I've had and continue to be active and think that there is a real hope of controlling this.
Yeah, that's very, very important. Most patients, again, with your disease, with IgA nephropathy, live long, fruitful lives. They feel very well. They handle their medications very, very well. And most patients can be kept from ever experiencing kidney failure or the need for dialysis and transplantation. In the very worst case, patients with IgA nephropathy actually do very well on dialysis and are the most frequent to move to transplant. Then on transplant, they do very, very well. So these words are all very, very scary, I understand, but we can work very, very hard to make those words never part of your reality. But even in that worst case, patients with your disease generally do very, very well. They live long lives, they live healthy lives, they can pursue all of their activities, and that's very important to understand right now, that this shouldn't be something that dwells on your mind every day, except for having it be a motivation to follow up with your doctors, to take wonderful care of yourself, and to have high compliance with your medications.
So when do we start?
Well,
Can we start now?
yeah, what we will do is we'll certainly want to start right away. Again, We'll review the low salt diet, slightly reducing your protein. It may be helpful to see a nutritionist so you understand exactly what that entails.
Can you refer me to one?
Yeah.
Since I don't know one.
Yeah, we work with a group of nutritionists, and we can refer you to somebody who's very familiar with the kidneys and appropriate diets. We'll work on the medications and your blood pressure monitoring, try to keep your blood pressure at goal with you monitoring it closely at home, and with making sure that the RAS inhibitor medication is well tolerated. The next step will be to see how your urine protein does and how stable your kidney function is by measuring the creatinine. And by looking at those values, we can then follow up, depending on your response to those initial changes, to see whether other medications should be discussed further and put on the table.
And how soon can I expect a change in my levels once I start taking the inhibitors?
You often will see improvements in proteinuria almost right away, but we like to see how you do over at least 90 days to see the full effects and to make sure you tolerate them really, really well.
Do we start at a smaller dose and build it up, or do we?
Well, we will start at a moderate dose. For you, because your blood pressure is already normal, we'll stay on the small to moderate dose. There is some evidence that the higher dosages you can use, the better we can reduce the protein in the urine, and then likely the better the disease will do over time. So we want to challenge that a little bit, but we don't want to make you feel sick. So if you do start feeling tired, lightheaded, dizzy, we've gone too far, and it's not worth it to push that too hard.
So that's almost the same effect I would feel if I had low blood pressure.
Correct, and that's what I'm
Same
talking
set-
about.
okay.
That's what we're looking for, is that low blood pressure effects, and sometimes that shows up when you measure blood pressures at home, and sometimes it just shows up that you feel crummy. But again, most patients tolerate these medications wonderfully.
Anything else I need to look for as I'm?
Not much. Patients often worry, and I'm sure you worry about, well, what's going to happen to me? But as I said, this is a very slow-moving disease, very, very silent. Some patients, unlike what you've said in your history, will actually have episodes of seeing blood in the urine, especially at times where they've had an infection, like just a regular cold or stomach flu. They wake up the next day and they see blood in the urine. And that can be very scary, but it is often just part and parcel of the disease. It doesn't necessarily mean that anything's getting worse, but if you were to see persistent blood in the urine or increasingly foamy urine, which is something that tells us that maybe there's more protein in the urine, that's something that we should discuss.
And so when you talk about lowering protein intake, is that just generally across the diet? Taking a look at different kinds of proteins to eat versus?
Yes, that's what we like to do. There's some discussion and some studies that have suggested that animal protein might push the kidneys worse than plant-based protein. There is not wonderful evidence that very low protein is going to benefit this disease. So we want to be sure you're not on a high protein diet, and we probably want to bring that down just a little bit below average. So what that turns into is a sort of gram per kilogram recommendation based on your body weight to get it down less than 1 gram per kilogram per day, and usually aiming for about 0.8 grams per kilogram. So again, that's something that the nutritionist can help you with. And again, just sort of cutting back your meat intake and your egg intake and your dairy intake a little bit, and having a little bit more fruits and vegetables and whole grains is probably a good start.
Great. Well, I really appreciate you taking the time. I feel a little bit better than I did when I walked in. I can tell you I was really nervous, and I think that this is a good sign. I think I wouldn't say beat it, but I can live with this.
Well, I'm happy to hear that, and with very close monitoring, we'll see what the next steps ought to be, whether it does mean moving into a discussion of these immunosuppressive medications like steroids or other drugs and discussing whether they really work or not, because as I said, we're not absolutely certain what works or not, whether it means joining studies as well, because this is an area of active investigation throughout the country.
So I've been part of a study before.
Oh, is that right?
And that interests me because I felt like I was doing some good.
Well, that's a wonderful thing, because there are several groups, including our own, that studies IgA nephropathy, because the present studies still don't lead to enough patients having a wonderful outcome without any worry of a future on dialysis or transplantation. We continue to look for the best way to treat it, and we continue to look for novel ways to treat that. So if you don't do very well with these early interventions, we can discuss other studies. There are also a lot of studies that just gather patients like you into observational groups so that we can learn from your experiences, and that may be something else that interests you.
I would be open to those.
Very good. Okay. So let's start with where we discussed things, and we will see how things come along.
Thank you very much.
Okay. Do you have any other questions?
No, that's been great, but I would look forward to being able to contact your office if I do.
Sounds great to me. Okay.